Welcome back. My name's Dave Minokian, and I want to thank you for joining me on this module. In this lesson, we're going to discuss building value for the comprehensive exam for existing patients. To this day, one of our biggest challenges is explaining the value of a comprehensive approach to our existing patients. When Mike and I first decided to move our practice in a different direction, we had a lot of patients in the practice that had been there since we were in grade school. And most of our hygienists had been with my dad from the beginning, about 30 plus years ago. I mean, credit to my dad and our loyal team members who stuck together for all these years because it created a family-like atmosphere for both the team and the patients. And we wouldn't have wanted to change this, but we feel that it did create a little bit more of a challenge for us. See, we believe building value with existing patients on why to take a more comprehensive approach to their oral health can not only come from us, the dentists, but the entire team has to play a role. And more specifically, we believe our hygiene team has to play the biggest role. In our practice, a lot of our patients have been with our hygienist for so long that some patients trust what the hygienist would tell them over what we would recommend. In the beginning, we were just the young sons, and who are we to tell them about the condition of their mouth or any concerns we may see? So one of our main goals was to make sure that the hygiene team was on our side and that they believed that this was the right thing to offer our patients. Without their support, it would have constantly been an uphill battle. We also had to continually tell ourselves and our hygiene team, stay confident and don't be scared of what the patient's response might be. We all had to believe that this was the right way to practice, so we just kept doing it, and over time, everyone bought in. We constantly stress to our team that we want patients to want to do dentistry to avoid the consequences of inaction. We believe the consequences of inaction are what really motivate patients to move forward with treatment. As an example, most patients will be quick to address a tooth with deep decay if we talk about the consequence of that tooth needing root canal treatment if left untreated. How about a crack in a tooth? I'm sure we can all think of consequences we can discuss with patients if the crack is left untreated. We'd probably be discussing things like fracture or tooth sensitivity. You'll find that consequences can apply to almost every clinical scenario, and it's a goal of ours to have all of our team members comfortable talking about consequences with patients. As a side note, consequences also apply to non-clinical areas of your practice as well. Things like not making financial arrangements or not scheduling a patient for a recall exam can have overall practice implications. It's really important for the whole team to understand consequences as it relates to their specific roles. We also remind the team that while discussing consequences, you don't want to try and scare the patient or make things up. Just be honest about the potential consequences. And most patients will appreciate the fact that you brought it up and likely respond more favorably to your recommendations. For us, using this PCS, problem consequence solution model, is a great way to have conversations about dental health. The most important thing is to have everyone consistently doing it in this order. Easier said than done. It's been a bit of a struggle at times because the tendency is to explain the problem and then immediately give the solution. Sometimes we all just skip right over the consequences. And when that happens, we found that patients are less willing to accept treatment. I think sometimes the consequences get skipped over because maybe they aren't always known. So to help with this barrier, we dedicated a good portion of another all-day meeting to discuss consequences of various types of problems. This definitely helped to make the team a lot more comfortable in talking about consequences in general. Even with that, we're constantly reminding our team to use the PCS model in its correct order and entirety. If we go back to the example of a crack in a tooth that we see during an exam, we inform the patient of our findings and usually take an intraoral photo to help the patient become more aware of what we see. A typical response of one of our existing patients is, "My tooth has been like this forever and it doesn't hurt." And this may be true, and we give them the option of doing nothing, but we feel if we don't explain the potential consequences and that tooth happens to fracture, then the patient could be more likely to blame us for not telling them that it could have happened. Now, once the problem and potential consequences have been discussed, we never just hand the patient a treatment plan. We always give treatment options and decide on the plan together. This co-diagnosis approach has worked very effectively for us. I believe patients tend to own their problems and ultimately accept treatment much more frequently, as opposed to us just deciding their plan for them. On some occasions, we felt like we needed more time to review our findings with the patient, so we decided to set up consultation triggers. We'll get into what some of our triggers look like, but this is how it works for us. If a patient falls into one of these categories, then the hygienist or doctor can recommend a separate consultation to discuss the exam findings. Again, this is something that's going to look a little bit different in all of our practices, and something that may vary from doctor to doctor within the same practice. What I mean is, if the doctor feels comfortable discussing one of the triggers in the hygiene room and feels the patient completely understands the problem, then there would be no need to bring them back for a separate consultation. On the other hand, if the doctor can't seem to organize his or her thoughts and senses confusion from the patient, then this would be a great time to offer the patient a separate consultation visit. This has really helped to reduce the stress in our practice in trying to have more involved conversation with the patient during a 5 to 10 minute recall exam. So let's look at our consultation triggers. We created these triggers based off the SPEAR model of EFSB, Aesthetics, Function, Structure, and Biology. We gave our team some specific examples under each category so they would start to understand what they should be looking for. Since our hygiene team plays such a big role in identifying these triggers, we have them ask a series of questions to each patient during the recall visit. And keep in mind, more times than not, there are multiple triggers involved with each patient, so for us, this system really helped with initiating conversation with the patient and identifying how many triggers existed. Feel free to create your own set of questions, but here's what ours looks like. Are you still happy with the appearance of your teeth? Do you have any sensitive areas? Have you noticed any shifting of your teeth or bite? Do you have any areas where food gets caught? Is there bleeding when you floss? And does floss ever break while flossing? Another great tool for our hygiene team to use in conjunction with these questions is the EFSB checklist designed by Dr. Gary DeWood. It not only helps our hygiene team identify problems more consistently, but also provides our patients with a prescription of their problems. This form can be customized for your practice, and a copy can be given to the patient to take home for review. So let's start with the aesthetic triggers. This would be patients that are unhappy with the appearance of their teeth. And I understand this is a very generalized statement, but the important thing for the hygienist and dentist to figure out is, what are the specific concerns of the patient? An easy way for us to start the conversation with existing patients is, are you still happy with the appearance of your teeth? If they are, we typically get a simple yes in return. If not, the patient usually brings up a specific concern, at which time we start to gather more information and see if we can discuss options at that time. An example would be someone interested in only whitening their teeth. These patients don't need to come in for a separate consultation, and we have the discussion at the recall exam. On the other hand, someone unhappy with the color of their teeth, as well as crowding and small lateral incisors, would be someone who we believe would benefit from a separate consultation. Again, come up with what works best for your practice based on different clinical scenarios and discuss it as a group. We also have functional triggers. Some examples would include an unstable occlusion, a patient that can't find a comfortable bite or feels like their bite is changing, TMD or muscle symptoms, or evidence of patients going into centric relation. These are all topics that we find to be way too involved to cover at a recall exam, and we do our best to explain the value the patient will receive by coming back for a separate consultation. Our structural triggers look like this. A patient that currently has structurally damaged teeth or has a history of structurally damaged teeth, such as cracks or fractures. Some of our patients believe that teeth that are constantly breaking down is just a normal process due to aging. And while age may be a contributing factor, we believe many patients can benefit from understanding that there may be other factors involved, such as their bite, that are contributing to the breakdown of their teeth. Then the question becomes, how can we help to eliminate those factors and reduce the long-term risk of damage? Other structural trigger examples include multiple missing teeth, multiple teeth needing restorations, and various types of tooth wear, such as attrition and erosion. Again, we believe that in order to effectively explain these structural problems in a clear and concise manner, a separate consultation should be considered. The fourth trigger, the biologic triggers, include things like periodontal issues and radiographic evidence of problems such as periapical radiolucencies or signs of resorption. For us, more times than not, these types of issues are able to be discussed at the time of the recall exam with the assistance of intraoral photos and radiographs. We stress to our hygiene and assistant team to try and identify these biologic problems and take the appropriate records prior to us coming into the room. They should begin to educate the patient as to what they see and why they are taking the radiograph or photo. By no means are they giving the patient a definitive diagnosis, but they can begin to come up with some possibilities. The hygienist or assistant then hands off the information in front of the patient, and we're then able to expand on what we see. This approach enables us to reinforce the problem and saves time, so there isn't much need for a separate consultation. That being said, at times there are multiple biologic issues going on that may require the assistance of a specialist, such as a periodontist, endodontist, or oral surgeon. If that's the case, and we feel like there's too much information to cover at the recall exam, we will reappoint a separate consultation visit to give the patient a clear understanding of how to manage the problems we discussed. In our practice, the patients we feel need a separate consultation visit because of one or multiple triggers will always require mounted models and photos which are taken prior to the consultation visit. If we have the time to do the models and photos the same day as the visit, then we will. Otherwise, we will set up a separate visit to take the appropriate records. The shortcut code we have created for a situation like this is CDM, which stands for Comprehensive Diagnostic Models. It typically includes upper and lower diagnostic models, a FACEBO record, and a centric bite record if needed. There's about 20 to 30 minutes set aside for the assistant to take the alginates or PVS impressions, and about 20 minutes set aside for the doctor to take the remaining records. We've also found that using the patient education software BiteFX and Spear education software during the consultation has really helped patients understand their current condition, particularly when it comes to functional health. The TMJ Tutor by Great Lakes Orthodontics is also a very useful tool to educate patients and increase awareness. The key is to find what works best for you to help deliver the right message to the patient. Before we wrap it up, I wanted to share with you what the consultation visit looks like in our practice. And this visit may look a little different in your practice, and that's okay, but this is what we have found has worked for us. We usually set up the consultation 1 to 2 weeks from the time we take the diagnostic records, and this time frame is the doctor's choice and usually dictated by the complexity of the case. On average, we typically have 40 to 50 minutes for the actual consultation visit. As far as the nuts and bolts of the consultation, we usually put together a keynote presentation utilizing the photos that we took and use animations and templates to illustrate various points. We used to start our consults the same way that we treatment plan, starting with aesthetics first, usually the lips at rest or in repose photo. And after structuring it like this for a while, we realized that there was more opportunities for patients to be confused because we weren't focusing on their chief complaint right off the bat. And we could almost sense patients saying to themselves, "This isn't why I'm here. Why is he starting the consult like this?" And we've since changed our approach. We typically start the consultation with a photo that recognizes the patient's chief concern so that they know we were listening to them and they become more engaged from the start. An example would be a smile photo for a patient self-conscious with their smile, or a maxillary occlusal photo for a patient that's concerned with multiple fractured teeth in the upper arch. That being said, our treatment planning process never changes. We utilize the linear approach of EFSB to organize the information in an easy way for the patient to understand. Even if a patient's only coming in for a functional consultation, we'll give them the opportunity to discuss the appearance of their teeth if they're interested. We also use the FACEBO to mount models on the SAM3 articulator and, if necessary, a centric bite record. We used to use simple hinge articulators, and then if the patient would commit to comprehensive dentistry, we'd have to re-articulate the models on a semi-adjustable articulator. Finally, we made the commitment to more accurate models up front. Mike and I have enjoyed sharing this module and hope it has given you some ideas to take back to your practice to give every patient the opportunity to take advantage of what comprehensive dentistry has to offer. Ultimately, we believe you will see patients that really start to buy into the process and a practice that continues to grow in a positive direction. We hope to see you again in future modules.